So I'm Caris Morgan. I'm a clinical oncologist at Velindre Cancer Centre, which is just down the road. And this is Caroline Methven, who's an oncology specialist nurse. We work together in Velindre, and we really treat most patients with GIST from South East Wales, if not all of them. There may be a few who haven't quite made it to our service yet. So we see patients who do need oncology treatments. And we come at this at sort of basically from a background of upper GI cancers. So I mainly treat patients with stomach, esophageal, pancreatic cancers, whereas some of you may have oncologists who come at this from a sarcoma point of view. The important thing is, to be honest, that your oncologist or your oncology team have experience in treating patients with GIST. And we've been asked to talk about the management of side effects of GIST treatments. And this is something which is incredibly important, and we'll come on to the reasons why that is shortly. And I wanted very much to keep this as a sort of practical guide to management of symptoms rather than any sort of science type of talk. So there's no horrible science slides. I just very much wanted it to be about day-to-day living with these drugs and treatments. Okay. So what I was going to say about why this is so important is obviously every individual patient with GIST may require more than one treatment. So someone, for example, who needs to have surgery for a GIST, they may undergo a major operation, followed then possibly by requiring some sort of drug treatment for a period of time. And then other patients who may present with more advanced disease, really for them, from the day of their diagnosis, they know that they're likely to require some form of treatment really lifelong. So this is living very much with this condition. That's a chronic condition, really, something like diabetes or epilepsy or any chronic condition. It makes it incredibly important that we manage side effects of treatment, because it's very much about living a normal life and having a good quality of life while on these treatments. So as I've got up there, what I'm mainly going to talk about is medications, because that's what we're doing on a day-to-day basis. And for us in our clinic, this is really bread and butter about what we do when we're seeing patients on treatment. Obviously, we're seeing new patients, but patients that come to clinic every 6 to 8 weeks or however often, they've often got problems related to these drugs. So hopefully you may have some suggestions about how you've managed some of the side effects. It'd be really helpful to hear those. I'm not going to talk too much about surgery, because there's a huge variety of operations that you may or may not need if you've got this diagnosis. But certainly surgery in itself can lead to potential side effects, or can mean that some of these drugs can be more difficult to tolerate. And I have also just very briefly mentioned radiotherapy on this slide, because in the past, I think there's been a bit of a feeling that radiotherapy hasn't got a role in GIST management. But on occasion, it can be a helpful treatment. And if you do have radiotherapy, there are often localized side effects. And again, I'm not going to dwell on that too much, because it's relatively small numbers of people who have radiotherapy, but more than happy to answer any questions about that. Okay? So if we're seeing a patient in clinic who has side effects, it's very, very important from a clinical point of view that we look at the whole picture. So what I was going to say really about this is that, an individual person on a drug, they may have other reasons for why they have that side effect. So have they got other medical problems? They may have other ongoing issues which are actually causing the problem. As I've already said, previous surgery can sometimes be a major thing, or interactions with other drugs that they're on. I had a lady, for example, who came to me for adjuvant treatment with imatinib, and she'd had a small bowel GIST, I think it was. She'd had quite a big small bowel resection. And when she started on the treatment, she got the most terrible diarrhea. And initially, obviously, the thought is that related to the imatinib? Very likely it is. But when she stopped the drug, which she had to, unfortunately, temporarily, the side effect didn't get any better. And interestingly, in her case, it was actually down to pancreatic insufficiency, so she wasn't producing enough enzyme to absorb fat. And once that was treated, she was absolutely fine and tolerated the imatinib no problem. So it is really important that we don't just say, right, this is definitely imatinib. We look at the bigger picture, the whole scenario. And I think the other thing is, in patients who are on treatment maybe for an advanced GIST, in the back of our minds, obviously everyone's worrying, is it related to the disease itself? So I think having an open mind about some of these problems is important. And I think this is where it is really, just to say again, useful to have a team that's used to dealing with patients with GIST, because it is relatively rare, and the side effects, they're relative, once you've seen a number of patients come through with similar conditions, it's much easier to manage problems that you see regularly, basically. Okay. So why is it, I've said some of this already, but why is it important to manage side effects? Well, quite clearly, quality of life is very, very important, particularly in people on long-term treatment. But we want to make sure the drug is safe and it's effective. And if it's not tolerable, then people won't take it, and it's not going to be effective. So it's a bit of a circle, really, isn't it? But I think, if we can't manage the side effects appropriately, people are going to end up with treatment gaps, and we know that that can affect how well the treatment works. And there is quite a bit of variability from person to person. Some people will get a problem with nausea, and another person, exactly the same drug, same dose, no problem whatsoever. So we do need to just be aware of that as well. And I think that avoiding interruptions in particular is something which we have over sort of many years realised is more and more important, basically. Okay. I just wanted to put this slide in briefly just because it's interesting, really. Compliance with treatment from the patient point of view can be variable. And one interesting thing, and it's obvious really, but if you have a patient who, say, for example, requires imatinib for an advanced GIST, they may present with quite a lot of symptoms related to their disease. They start on imatinib, and within 48 hours, they feel better. And that's quite common. People feel much better quite quickly. And if they then develop side effects from that treatment, maybe some nausea or something like that, they're much more likely to say, oh, it's fine, I'll put up with it because I feel so much better for the drug, I can see it's working. And if you compare that to a situation where someone's having adjuvant treatment, so they may be having imatinib for 3 years to reduce the risk of recurrence, but they have no disease on board, as it were, and they don't have any symptoms. So when they get the problem with nausea, you can imagine they're more likely to stop the drug. They're less likely to be compliant because they can't see the benefits as clearly as someone who's got much improved symptoms. So we do see a difference in compliance between different clinical scenarios. And interestingly, in the large trial that looked at 3 years of adjuvant imatinib, there was quite a high 25% discontinuation of imatinib, which is high, isn't it? But I suppose it was because the patients who were on the 3 years didn't know if it was going to be beneficial to them. And as they say, they had no symptoms to be treated. So I think that we have got some work to do, obviously, to try and get that better. And I think hopefully knowing how beneficial this treatment is has probably helped. Okay. So I was going to talk now, particularly with Caroline, about some more practical things about managing side effects. So, thank you. First drug is obviously imatinib. And I'm sure a lot of people here, if I had a show of hands earlier, have either been on this or maybe on it. Okay. So, I'm not going to talk too much about this slide because I promised you not to go down any sort of science slides, but it was the first effective drug for GIST. Prior to this, as you know, there weren't really any effective treatments, so this has been an absolutely remarkable drug. And it sort of outlines the importance of research, doesn't it? Because until we knew how GIST develops, it was very difficult to find a treatment. Once the understanding of how the tumour is driven was known, it was able to be targeted with a very specific treatment. So this has obviously transformed the whole field. But it does have some side effects. I'm sure that everyone here who's been on it has had side effects. Okay, thank you. Pop to the next slide. Oh, thank you. So there we go. So I think that we can probably say that most side effects of imatinib are relatively mild in the vast majority of patients, although not everybody. And the interesting thing is that they can often start off as more of an issue and then actually improve. So somehow the body seems to get used to them, and particularly things like the fatigue can actually improve quite quickly, although certainly not for everyone. In about less than a third of patients, the side effects can be more severe. So that we don't by any means take this lightly, because we have seen people where the side effects are so difficult that it's almost impossible to continue the drug. So we do need to manage them as soon as they start to appear. So very commonly we see that fatigue is a problem. The most common side effect here is fluid retention, which I'll come to in a second. But also there are quite often quite a lot of side effects on the gastrointestinal system. So that could be anything from nausea to diarrhea. I don't know if anyone here has suffered from muscle cramps related to imatinib. That is certainly another common one. I have to say it's very difficult, in fact, to treat muscle cramps. I don't know if you've got any tips personally, but I've tried patients, they've tried quinine or G&T at night, or calcium supplements and things like that have sometimes been suggested. Massage, okay. And certainly Caroline's got something to say about complementary treatments like massage. But I think that can, for some people, be a real problem. So this is, go on a bit. Okay, we're going to go back. That's a picture of the typical periorbital edema. So that basically is one of the side effects that's related to fluid retention. Very typically, you can get this sort of puffiness around the eyes, particularly in the morning, that improves throughout the day. We sometimes see that. The other thing that people often complain of is swelling of the ankles, and that can be, again, worse in the morning and improve through the day. And now and again, particularly in elderly people who have got cardiac issues, so if they've had heart failure, you can sometimes get a much more severe form of fluid retention, which can lead to fluid on the lungs or heart problems, and that's much more difficult. I have had a couple of patients with these sort of underlying conditions where you have to be incredibly careful if introducing imatinib. So there's a small group of patients where that can be an issue. So fluid retention-wise, it is difficult again. Some people have sort of recommended reducing the salt intake, and I think that can help. The other thing that's often brought up is diuretics or water tablets. People describe, could I have something to get rid of this fluid? And you might find that your oncologist is slightly reluctant to do that. And the reasons for that is that sometimes that can have side effects, and it can cause problems with low blood pressure or what's called postural hypotension, when if you stand up quickly and feel very faint and fall. And because what we're doing with a diuretic is getting rid of more fluid via the kidneys, and that can lead you to be a bit more likely to be dehydrated, for example. So it's difficult because we do certainly take this side effect seriously, but what we don't want to do is introduce another drug which makes it worse. So sometimes actually, it can improve a bit with time, and just monitoring it, in fact, is better. Reducing the salt intake might help. But in not extreme cases, in more difficult cases where it is really, really persistently a problem, occasionally, diuretics are used. Okay? And then we're going to talk, I was just going to mention about the GI side effects, and Caroline, in fact, is going to tell us a little bit about managing these, because these are also something which there are treatments for, which can be persistent for some people and can really affect how well people manage to take the drug. So what I mean by GI side effects is side effects affecting the gastrointestinal tract. So that could be anything from feeling sick, nausea, to indigestion problems, and to the other thing being diarrhea. So Caroline's going to talk us through some of the ways of managing that.
Hi, hello. We're starting from the top, really, and working down. So nausea is quite a common side effect. It doesn't usually lead to vomiting, but can do in some cases. So ways of tackling that are taking it as prescribed with food. Sometimes we recommend taking it before bed, so that if you are feeling nauseous, you're kind of sleeping through it and it's not interrupting how you eat during the day. That can help. Having small, frequent meals throughout the day rather than large, perhaps fatty meals can help. And hunger tends to make nausea worse, whatever the cause. So allowing yourself to get hungry can make things worse. So again, small, frequent meals. There is some guidance about having the imatinib in divided doses, so perhaps having 200 milligrams in the morning, 200 at night. I think there may be some issues about the licensing on that, but it is something that some of our patients have tried and have found to be effective. You need to have the 100 milligram tablets to be able to do that. So if that's something you want to try, you can request that. In general terms, ginger is often helpful for nausea, either kind of raw, crystallized, in teas, biscuits, things like that, that can help. And then we do often use antiemetics, so we do use anti-sickness medication to try and help. And there are a lot of anti-sickness medication out there, varieties. So if you try one and it doesn't work, look at alternatives. Dyspepsia, probably slightly less common. So that's kind of indigestion, acid reflux, those kind of symptoms. Again, it's often around diet and food, managing it in that way. These drugs called PPIs, which kind of switch off the acid in your stomach, they can be very useful and they're generally well tolerated. A common one is omeprazole. Again, it's kind of about diet, small frequent meals and avoiding spicy foods, alcohol, things that are likely to irritate the stomach. Diarrhea, as Caris mentioned, that can be quite a problem. And it varies in severity and it varies in frequency. And how people manage it in their life varies as well. So, but common ways of things to think about when you've got diarrhea are your diet. So having a low residue diet, for example, avoiding things like caffeine, alcohol, things that can kind of irritate the gut.
There's no fun in life.
No fun in life. And fruit. Lots of fruit will obviously make diarrhea worse. Need to be sure that you're getting enough liquids in when you've got diarrhea, and that can be difficult if nausea is a problem as well, but try and drink as much as you can. Loperamide is an anti-diarrhea drug that we use a lot. Imodium is another name for it. And it's useful, it depends on the severity of the diarrhea, but it is useful to be quite proactive with loperamide. I've noticed in a lot of our patients that there's a kind of reluctance to use it. I think some people fear they're going to become constipated or that they're going to become dependent on it. But it is a very good drug. And it's particularly useful, I think, if the diarrhea either is severe or it's impacting on what your activities are. So some people find that they limit their activities, going out and so on, because they're worried about the diarrhea. So using loperamide in a kind of prophylactic way can be helpful too. If you've got a particular thing you're worried about going to and you don't want to have diarrhea, then you can use it prophylactically. But also, taking it regularly, taking it as prescribed, it is a very useful drug. I've also been advised, and I don't know if any of you have had experience of this, that marshmallows and Haribos are also very good for diarrhea. So you've got carte blanche to eat those. And apparently grated apple. If you grate apple, it releases the pectin in an apple, and that can help settle diarrhea. Obviously, if it's severe, those things are less likely to help. But if you've got a kind of loose bowel, it's worth trying some of those things.
Okay. So moving on to the next drug that people may be treated with, sunitinib. So sunitinib is usually used as a second-line treatment for GIST, and it's not quite, it's slightly different in the way it works to imatinib. It's got multiple targets. So as you would expect, the side effects are slightly different and can be more severe. But I think, again, if managed well, can usually be surmountable. Basically, when the trial was done looking at GIST, the dosing regime that's up there was the one that was used. So it was using a dose of 50 milligrams, which you take basically every day for 4 weeks, and then have a 2-week break from treatment. And I have to say that dose, I find, for some patients can be quite difficult to tolerate. So people may be on that dose and the side effects can come on quite quickly. So there are other ways of taking the drug that are not licensed, as it were, for GIST, but we know from experience in kidney cancer and some other, like neuroendocrine tumours, for example, that other ways of taking the drug can also probably, most likely be as effective. It's just that the trial was done using this particular regime. So I have a number of patients on sunitinib who are certainly not on this particular dosing regime. We've sort of modified it to suit them. I'm sure that you'll find that your oncologist would do that. So just in terms of the side effects of sunitinib, you can see up here there's quite a long list. I've sort of grouped them together. There's the similar ones to imatinib in terms of the GI side effects. Diarrhea can be much more of a problem with sunitinib, I would say. So that is something we need to manage quite proactively. I'm going to show you in a minute, but not quite yet, some pictures of some skin changes. There's this, what is described as hand-foot syndrome, where you can have quite a nasty reaction on the hands and feet can happen with sunitinib. And you also sometimes see pigmentation changes. There's another thing, which again I got a slide on, which is something called stomatitis, which is affecting the mouth, and I'll come on to that in a bit more detail. The other things on here, well, we know that sunitinib can increase the blood pressure, and it can cause the kidneys to you can lose protein via the kidneys. So these are certainly things that we need to monitor in clinic. Often people may have high blood pressure anyway and be on treatment for that, but it can go up further. Or patients who've never had a problem can develop hypertension. So it definitely needs to be monitored, and we often have to work quite closely with GPs to make sure that it's monitored often in the community. The difficulty obviously with coming to clinic is we do a blood pressure in clinic, it's slightly elevated because you're a bit stressed about going to clinic. So often we do need to work quite closely with primary care on that. And sunitinib can affect the thyroid function, so in particular it can lead to an underactive thyroid over some months of taking the drug. And this can be relatively insidious in terms of the symptoms. People can feel a bit more tired, they can just feel more cold, some other symptoms that people can get which can be relatively difficult to pick up actually. So it is important to monitor the thyroid function, and we do check that intermittently when patients come to clinic when they're on sunitinib. Very rarely sunitinib can cause similar effects on the bone marrow, so it can cause anemia, and again that's part of the reason why we check the blood count. Less commonly it can affect the white cell count, which increases the risk of picking up infections. I have to say I've very rarely seen that as a major issue. Okay, so this is just a little diagram that I found which shows the sort of skin side effects that you can get with these type of drugs, not just sunitinib, but there's a group of drugs like this. It's basically the hand-foot skin reaction I'll show you in a minute. It is just to remind me to say that some people do get some hair thinning with sunitinib. And there is a description of hair growing back and being curly. So I don't know if anyone's had that. But it also can cause a lot of pigmentation of the hair, so greying of the hair, which is sometimes unexpected. Then what it's basically showing is that, particularly in the sun-exposed areas, face and chest that it's got there, you can get some redness of the skin or change in colour of the skin. And some people do get a rash, which is a bit sort of a bit like acne, I suppose, and that can respond quite easily to creams and things, and it does tend to improve a bit with time. But the main things that I have to say that I find that people have problems with is this hand-foot skin reaction. So just coming on to that. So on the picture there, you can see that the patient's hands, there's some blistering with some redness around it. And usually if someone's going to get this, they get it within the first month of treatment, so it comes on relatively quickly. And it starts off with some tenderness or redness of the skin. And then, particularly over the areas where there's pressure, you can get some blistering, which can then develop into sort of thickened skin and callus formation. And it can, if it's left and not sort of dealt with early, can be quite difficult and painful. So these are things that obviously we want to pick it up when patients come to clinic. If they've got redness or soreness of the hands, that's a sign that if we don't consider, doing something about it, which we'll talk about in a minute, it might get worse, and we don't want to end up with nasty blistering of the hands. I was going to warn you about this slide because it's not very pleasant, but this is just an example on the feet. You can see there's sort of very thickened skin, hyperkeratotic it's called, so you get those calluses over the areas of pressure. And we want to try and avoid this sort of thing happening. So I think, in fact, Caroline, you've got some practical suggestions about how we can try and prevent this developing in the first place, and if it does develop, how we manage it. Okay, so that's on the, yeah,
Thank
get rid of that picture.
Yeah, some of the preventative stuff is very similar to the management, really. But a good moisturising regime is really helpful. So, just getting used to, particularly the hands and feet, using ideally a moisturiser without much chemicals in. So the E45 is one common one. Urea-based creams have been shown to be useful, and we recommend something called Udderly cream. Unfortunately, we're not able to prescribe it, but we can give samples out for people to try. There's some smiles. I don't know if you know about Udderly cream. It was a cream that was developed for cows' udders, but has found to be useful with the side effects of a lot of anti-cancer drugs. And Aveeno cream is also very good for rashes that can form. Sometimes it's useful if the hands are badly affected, so that you're getting really good moisturiser, to slather your hands with the moisturiser and then wear gloves, cotton gloves over the top, particularly at night, so that they've got a really good chance to absorb that. Avoiding overly hot water, that's for a kind of comfort point of view, but also that can damage the skin further. We would recommend taking really good care of your feet, rather in the way that diabetics are encouraged to monitor the condition of their feet. It can be worth having regular podiatry or chiropody checkups, so that any small kind of lesions or areas of pressure can be looked at, monitored, advised on. So foot care, it is really important. There are can you just pop that? Sorry. There are apparently 1,000-mile socks. I don't know if you're familiar with those, but they've got a kind of very nice, soft, smooth lining, and they're designed to reduce the friction on the foot when you're wearing them. So they're useful. And using insoles, soft insoles, gel insoles, making sure your shoes fit really well. Avoiding friction. That's not rows in the family, that's things that will abrade the skin in any way. We've talked about those creams, and sometimes some people take good care with the moisturising creams, but then they kind of are using quite harsh showering products. So there are some emollient creams that you can use as a shower wash if your skin is quite badly affected. Sometimes you do need to have pain relief because those effects can be quite painful. And as Caris has said, sometimes we need to have a break in treatment to allow the skin to recover, because what we don't want, which is the whole point of this talk really, is we don't want these side effects to become worse than the disease itself. So we may need to have breaks in treatment or dose changes.
Okay. So the other thing that sunitinib certainly can do is cause what's called stomatitis. And basically what that is inflammation of the oral mucosa. So it can be sore gums or mouth ulcers. Sometimes people get a sore tongue. And you can look and sometimes just see redness, nothing much else. And in other people, you can actually see mouth ulcers which look really uncomfortable. And in the worst case scenario, it could lead to someone finding it quite difficult to eat, for example. So again, we do need to manage this early. So about 3%, so it's relatively rare for it to be very severe. But now and again, and it can be a little bit unpredictable, someone does get a very nasty episode of stomatitis. And as with the hand-foot syndrome, it's often early on in treatment when it appears. So for when starting a person on a new drug, then certainly you tend to want to see them a bit more regularly than maybe once they're established on it and stable. So for prevention of that, then again, a bit like the feet care thing, regular dental checkups and going to the dentist and making sure there's no major problems before starting the drug is a good idea. We usually recommend alcohol-free mouthwashes and using those regularly, twice, 3 times a day, and using a much softer toothbrush than you would do usually. So whether that's more of a children's one or it's just a soft one, that can help. So what you don't want to do is damage the gums with any sort of over brushing. And similar to before, certain things this is very much depending on the individual, but certain foods, spicy foods or very sort of acidic foods, can make it worse. And it's really important to make sure that you're getting enough fluids, because certainly if you start to get a bit dehydrated, the mouth, if just everything gets really stuck down, it can actually be quite a lot worse. Obviously, smoking can make any of these sort of side effects, but particularly the stomatitis, much, much worse. So we obviously don't recommend smoking. And some people find that alcohol can sting quite a lot, so that probably is best avoided if you've developed any issues with this. Gel Claire, Caroline, I forgot to mention that. So there is a treatment. We haven't used it too much, but certainly colleagues who treat patients with the same drug for kidney cancer have recommended this. If someone's got already developed problems with this, there's a treatment, a drug called Gel Claire. It's not really a drug. In fact, it's a gel which coats the oral mucosa and covers and sort of protects the gums or wherever the problem is, when it helps when you're eating. So it is something that can be used if necessary, basically.
Just also take care of the lips as well, so even if they're not directly affected, using Vaseline or something to protect and moisten the lips. And some people find that sucking ice cubes, flavoured ice cubes, is soothing to the mouth. Keeping pineapple chunks in the fridge can be nice to kind of suck on and soothe the mouth. And some people, in the short term, because hopefully we would address this in the longer term, but in the short term, if drinking is a problem, then sometimes drinking through a straw is more comfortable.
Okay, and then certainly if someone develops any of these side effects, to a point where it's affecting quality of life or making it difficult to take the drug, we certainly need to look at the dose regime, and that 50 milligram dose for 4 weeks is, as I say, quite difficult for a lot of patients. So sometimes a continuous lower dose, so we drop the dose down to the next level, but maybe try it on a continuous basis, and that can be much better. And I also have some patients where we've gone for a regime where you take the drug for 2 weeks and then have a week off and take it for a further 2 weeks. So we're just sort of splitting it more over that 6-week period. Because sometimes towards the end of the 4 weeks, obviously, having taken it every day for 4 weeks, the side effects have been able to build up. So that can be a lot more tolerable as well. So just making these small modifications can make it a lot better tolerated. And there are other doses than 37.5, and I certainly have had patients on lower doses where it still continues to be very effective treatment. So we have to individualise it, and I know it's not really what the sort of licence is, but we have to individualise it to make it manageable in the longer term, basically. Okay, so just on the next one, so certainly in clinic, just if you are on sunitinib and go to clinic, there's a few things that we would certainly want to make sure you're having checked regularly. We usually would do a baseline heart tracing or ECG, and that's just to make sure there's no underlying issues. Just because there's a very small chance of developing cardiac problems on sunitinib. We would also just talk about that and warn patients about any symptoms to look out for. We obviously check the thyroid function, as I said. We want to make sure the blood pressure is closely monitored, and usually attending the clinic, we'd like to dipstick the urine now and again to make sure there's not any increasing protein loss in the urine. I don't know if you've seen these patient diaries that sometimes your hospital may produce one, or there are some available from the drug company that produces sunitinib, and that can be quite helpful. Some people find it useful to write down what sort of side effects they get, so they can see if there's a pattern to it. We've probably got a couple of examples of those, but they can be really helpful for some people. Okay.
So the pattern can be useful to kind of guide us in how we treat the side effects, but it can also be useful for you as a long-term management thing, so that if you identify a pattern, you may be able to find times where you're less affected, so you can kind of plan things around that.
Regorafenib, I don't know if anybody here has actually been on regorafenib. So it's relatively new, quite relatively recently introduced and available in the UK. It's now used as a standard third-line treatment for GIST. I've had a few patients on it, and it works in a similar way to sunitinib, but is thought to also work on secondary mutations that develop, and that's why it's probably effective in some people. I have to say, in my experience, it is a more difficult drug to tolerate than sunitinib. So the side effects are similar, but just can be more severe. So it's really important for this particular drug that we monitor people closely, particularly when they first start on it. There's been a couple of interesting reviews about management of regorafenib toxicity that I've read, and I think the main thing is make sure that patients are monitored closely, and actually if the side effects start to build up and flare up, really then stopping the drug, allowing it to settle is actually quite important, which is a little bit different to some of the other treatments. Okay. So the dose that, again, is recommended is 160 milligrams for 3 weeks and with a week off. But in the trial that looked at this, that showed a benefit to this drug, 72% of patients within that trial, and they're fit patients usually that go into trials, they required a dose reduction. And that very much, I think, is borne out in my clinical experience. I don't really feel that, I think it's really difficult to tolerate 160 milligrams without getting any side effects. So similar side effects, as I mentioned, but just more marked and often coming on within the first few weeks of treatment. So I do usually recommend seeing the patient regularly every week or so, in fact, for the first couple of months of treatment, depending on how they're getting on, just so that we can pick up side effects early and act on it. I do think the other thing I found is that some, understandably, some patients, they're on third-line treatment and they desperately want to take the drug so that it'll have an effect. And so we want to make sure they're not underplaying the side effects so that we can act on them early. And if it's just a matter of reducing the dose so it's tolerable, it seems to be a very reasonable thing to do. So I'm not, in terms of management of side effects, it is similar to sunitinib in terms of the overall pattern of side effects. It's just that they're more severe and they come on more quickly. Okay, so really that is what I was going to say about regorafenib. I think that when I'm starting a patient on regorafenib, it's just important that we educate that person about the potential for side effects, because we know that it's higher than with the previous other drugs. So I think it's just that, and being flexible with our clinics so that if someone rings up and needs to be seen because they've got sore feet, they very much want to see them. And we try, and because of the way we work, we try and make sure that's possible. And I think that hopefully means that we can pick up the side effects early, really. Okay. Just a brief mention of surgery. I wasn't obviously going to talk about this in detail, but as you know, GIST can arise anywhere in the GI tract, and that could be from the esophagus down to the rectum. So the type of surgery that people require for GIST can be, incredibly varied. But I think that we do need to just remember when we're seeing patients, certainly with GIST, that sometimes the side effects post-operatively may be due to the actual anatomical changes that the patients had. So we do need to also liaise a little bit with our surgical team. So it's just something from a clinician point of view that we need to be aware of. So some of these operations, they're quite extensive. And also we see patients who undergo, for example, liver resections and other surgeries, even in the setting of advanced GIST. So just another mention really that multimodality treatment is quite normal in this situation now. Okay, so Caroline was going to talk a little bit about support, because of the way, and we can talk a little bit about how we work the clinics. Just obviously everyone's got slightly different experiences of where they're treated, so hopefully there'll be some information for you about support for GIST patients.
So Caris Morgan is our local lead on GIST, and I've been working with Caris for some time. And a few years ago we felt that we were seeing patients with GIST in the middle of very busy, quite intense, often with lots of delays, upper gastrointestinal clinics, and we felt that that wasn't really doing the GIST patients a really good service. So we decided to set up a nurse-led clinic. So I'm a clinical nurse specialist, but I'm also what's called a non-medical prescriber. So it felt that it was a good opportunity for me to use my prescribing skills to allocate a different kind of setting, a slightly quieter time with a little bit more time, and an opportunity to get to know patients over and have that continuity of contact. I think, as Caris said, for many people it is treated really as a chronic condition, and as such it's really important that we make our treatments work around your lifestyles. So there are lots of people who want to carry on working, who have other family commitments, activities they want to do. And having the nurse-led clinic allowed us to offer a bit more flexibility about seeing people, but also about developing that kind of continuity so that we really get to know our patients, what is mattering to them. So, for example, something like the symptom of diarrhea that we talked about, you know, depending on your lifestyle, that can have a different kind of impact. If you're trying to work or you've got other activities that you want to be involved in, it may be the diarrhea has a bigger impact on that. So it's kind of about taking a more holistic approach, really, to the patients. The long-term, the chronic illness kind of approach also can lead to quite a bit of uncertainty about the future, and individuals vary on how they manage that. And within individuals' lives, there will be times of greater uncertainty and greater anxiety around that. So we look at how we can help people manage that uncertainty. And we can also call on our colleagues in the psychology service or local counselling services if that's an issue. I can also signpost to other services like financial advice, and we sometimes write letters to employers on our patients' behalf, because I think for some people, they look well. It isn't a kind of cancer that people are familiar with, and sometimes family and employer expectations just may be a bit skewed because of that, and we can offer support in that way of just highlighting what some of the issues are. I wanted to talk a little bit about complementary therapies. So I'm including in that therapies that are non-pharmacologically based but offer help with symptoms and general well-being. And we're able at Velindre to offer referrals to the complementary therapy service, but a lot of people can access that through GPs or privately. And it can be very good with helping people with quite specific symptoms like diarrhea, nausea, pain, bowel disturbance and cramps. And you mentioned massage, and certainly we've seen some benefit from massage, particularly in the hands actually. And often the cramp in the hands is quite debilitating because it stops people being able to get on with activities. So massage can be quite useful for that. I would include things like reflexology, where areas of your feet are massaged, relating to different systems within the body, and those can be very helpful for symptoms. And Reiki, which is a kind of hands-off healing. It's a little bit vague to talk about, but often people find that helpful for kind of general well-being, anxiety, sleep disorders, those kind of things. And also for blood pressure, so high blood pressure. Generally, we would look to use anti-high blood pressure medication, but actually some complementary therapies can be good at helping people manage their blood pressure. Wanted to just also mention something called Look Good, Feel Good, which I'm not sure how many of you may know about, but this is a charitable service that's offered to patients who have had gone through anti-cancer treatments and may or may not have physical changes as a result. But it's mostly focused at women, I have to say, but it should be available to men as well. So it's looking at things like hair care, makeup, skin care. So if you have lost the colour in your hair or your eyebrows, sometimes people's eyebrows and eyelashes go white, it can be quite a nice thing to get some guidance about how you cosmetically manage those things. That's particularly with sunitinib, the hair colour loss. And diet, really, that's kind of, we've touched on some of that, but eating healthily, managing the symptoms through diet, and we have access to a specialist dietitian, so we can always ask them for advice on various things, and you should be able to access that yourselves either through the GP, through your oncology service, or through a community dietetic service. Thank you.
So I think that was mainly what we wanted to cover today, so I hope that was helpful and practical for you, but we're more than happy obviously to answer any questions that anyone's got.
Thank you very much.